So there are a lot of really exciting combinations currently being explored with PARP inhibitors. And I think one of the more exciting combinations is olaparib and cediranib. So cediranib is a VEGF tyrosine kinase 1, 2, and 3 inhibitor and is thought to mediate BRCA downregulation. So the really cool thing is that we are hoping to kind of leverage synthetic lethality and take tumors that are HR proficient and basically turn them into tumors that are HR deficient. So this was explored in a phase 2 trial that looked at olaparib versus olaparib with cediranib in patients with platinum-sensitive recurrent disease. And the group that got olaparib and cediranib had a significantly improved progression-free survival compared to the olaparib alone arm. The median progression-free survival was significantly increased in patients that received cediranib and olaparib as compared to olaparib alone. Now, this data was recently presented as an updated version, and interestingly found that there was not a significant difference in progression-free survival in patients that had a known BRCA mutation, but there was an even larger difference in progression-free survival in patients that had an unknown BRCA or not known BRCA mutation, 5 months as compared to 23 months. So in order to further explore this, there's a phase 3 trial that is currently recruiting patients evaluating olaparib alone as compared to olaparib and cediranib compared to platinum-based chemotherapy in patients with platinum-sensitive recurrent disease.
I think in general, the combination of PARP inhibition and anti-angiogenic therapy is biologically very plausible and very interesting to pursue. The anti-angiogenic drug deprives the tumor obviously of important nutrients and oxygen by decreasing the tumor vessel density. That by itself can decrease most likely the expression of genes and proteins that are involved in homologous recombination repair. And that makes the tumor likely more sensitive to PARP inhibition. Therefore, I think that the combination of a PARP inhibitor with an anti-angiogenic therapy is likely to have at least some additive efficacy. It's hard to predict what combination, either olaparib with bevacizumab or another anti-angiogenic drug, or niraparib with bevacizumab will be of differential efficacy. Given that PARP inhibitors at this point seem to have rather equal efficacy, I'm not comparing trials to each other, but we have to, when we look at the data, say that there's no much tangible difference in progression-free survival, at least not on the maintenance trial. So if that's the case, and we assume that the biological efficacy is similar, maybe the clinical efficacy in this combination will not depend necessarily on the PARP inhibitor, but maybe based on, again, patient selection. And those patients might be the ones that are BRCA1 non-mutated. We have actually data from one trial that Dr. Matalonis published a couple of years ago, which showed that those patients on olaparib combined with cediranib, another anti-angiogenic drug, those patients that don't have BRCA mutations benefit the most from this combination. And that again probably goes back to the idea that anti-angiogenic drug decrease the expression of HRD genes and hence increase the sensitivity to PARP inhibition. Now we have to verify this data in clinical trials. Any trial that will investigate a PARP inhibitor or combinations of PARP inhibitor with anti-angiogenic drug or immunotherapy will need to really carefully look at mutation spectrums in the tumor and then correlate responses with those somatic mutations. The combination of an immune checkpoint inhibitor like niraparib with pembrolizumab, which is actually ongoing, is, I think, a very exciting one. Immunotherapy is mostly effective in patients that have a high tumor mutational burden, have a high expression of neoantigens. PARP inhibition actually can increase the expression of neoantigens and hence immunotherapy might work better. We also know that those patients that have BRCA1 and 2 mutation have a microenvironment in the tumor that might be much more responsive to immunotherapy. For example, we see more cytotoxic T cells infiltrating those tumors in patients that have BRCA1 and 2 mutations, either in the germline or in the tumor tissue. Hence, the microenvironment might play a major role in conveying a response to this combination of immune checkpoint inhibition with PARP inhibition. I'm personally very excited about these type of trials since I think that combination will very likely increase the efficacy of PARP inhibition.
So when we look at other combinations with PARP inhibitors, it's perhaps that we may be able to think about low-dose chemotherapy. We do have trials looking at veliparib, which is not FDA approved, in combination with upfront chemotherapy. But we may see our ability to use some of the FDA-approved PARP inhibitors in combination with lower-dose chemotherapy, maybe a strategy that gets developed over the next few years. And then obviously very exciting combinations with our antivascular agents and our immunotherapy agents.